Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Jacob Møller in Copenhagen, Denmark, in order to discuss his Danger study, a landmark study from this year's American College of Cardiology meeting, which tested the prognostic implications of a microaxial flow pump versus standard care in infarct-related cardiogenic shock. Dear Jacob, we are so honored to host you tonight. Thanks for being with us.
Thank you for having me.
So welcome everybody to a new episode of Marcus at Home today. Our topic today is cardiac intensive care medicine, and we want to focus on the field of cardiogenic shock today. Our special guest today, as Gunnar mentioned, is one of the leading experts in cardiac intensive care medicine, and we're really happy and proud to have him here today. It's Professor Jacob Eifer Møller. He's Professor of Medicine at Odense University Hospital, and he's also working at the Rigshospitalet University Hospital in Copenhagen. And among his many fields of research and interests are cardiogenic shock, mechanical circulatory support, and cardiac arrest. And among many seminal studies, he contributed to the Box trial and, of course, to long-awaited Danger Shock trial. I must admit, I really love that name. And he's the principal investigator and published this in the New England Journal of Medicine recently. As usual, we are really happy to have another outstanding expert in the field today with us, is Professor Stefan Desch. He's Vice Director and leading consultant at the Department of Cardiology at Heart Center Leipzig in Germany. And of course, our viewers are aware of the fact that Leipzig, since many years, is a leading institution for cardiac intensive care research. And so we're really happy to have you here today, Professor Desch. Okay, without any further delay, now the stage is yours, Professor Møller, and we're really happy to and interested to get some insights into Danger Shock.
Thank you. So I'm here on behalf of all the Danger Shock investigators, and thank you for this opportunity. I have some disclosures that are seen here. So the background for this study goes many years back. We started designing the study in 2011 when the Impella CP just started to emerge. Our hypothesis was that this device could do some good in patients with predominant LV failure. So these other phenotypes we tried to exclude from the study, and I'll elaborate a bit more into that. So basically, we targeted STEMI patients. We targeted patients where we had made sure that the LV function was down and there was not a contraindication to place an Impella, and lactate had to be elevated. Patients could be randomized before PCI, during the procedure, up to 12 hours after procedure. We excluded comatose cardiac arrest, and we excluded right heart failure and mechanical complication. And I'm just going to discuss a little bit more into depth this cardiac arrest exclusion. So if you take a patient like this, patient 65-year-old female, witnessed cardiac arrest, bystander CPR, massive anterior ST elevation, and routed into the cath lab comatose with a blood pressure of 85. Her ejection fraction is somewhat reduced, lactate is 9. So this is a situation that is very difficult to separate from what I would call the LV predominant cardiogenic shock. But only 4 hours later, the lactate is normal, the SVO2 is 66%, the wedge pressure is more or less normal, and she's managed almost with no vasopressor and no mechanical circulatory support device. And putting a patient like this on a device would only expose this patient to the complications of the devices. If we look in the Box trial, where we studied about 800 patients with cardiac arrest, like this patient that was also enrolled in the box trial, we see that about 40% of the population would have been eligible for the ECLS shock trial based on the criteria. But we used mechanical circulatory support in 1% of these patients, and we had a 1-year mortality of 37% in this population. And it's another phenotype. Also looking at lactate. So when these patients come into the hospital, this is the prognostic importance of measuring lactate in the cath lab. So a patient coming in with a lactate of 5 that has suffered cardiac arrest, we find have a mortality of around 43-44%. But a patient without cardiac arrest with the same lactate level has a mortality of more than 60%. My take on this is that the lactate in the arrested patient is really a measure of the low flow period, whereas the patient coming in without cardiac arrest, it's much more reflective of what's going on with the circulation at the moment you see the patient. Also, the causes of death are fundamentally different. This is Lise, who did some analysis in our shock registry looking at the causes of death, and found that patients that had suffered a cardiac arrest, the main reason for death was brain injury, whereas in the LV predominant phenotype, it was refractory shock that was the predominant cause of death. And these devices cannot save the brain from an insult that happened outside the hospital. So we excluded cardiac arrest. We targeted this STEMI phenotype, and then we randomized as soon as we saw shock, either to have the impeller placed and then do the revascularization, or try to revascularize the patient and start the inotropes and pressors. Patients could be escalated at any time. So in some of the most severe cases, we had the ECMO team in the room and just doing the randomization. And if patients were randomized to control, they went straight to ECMO. So it's not a study of impeller versus medical therapy. It's kind of two strategies. It's a strategy of placing the impeller up front, or a strategy where you wait and see, and if things deteriorate, you put the ECMO in. Then we followed the patients for 180 days. This was chosen based on the shock trial when we designed the study. Today it was a lucky punch, but it was really driven by the results of the shock trial. So we thought we had 3,000 STEMIs in Denmark, 10% are in shock, so this would be done in 5 years. But when we started to understand these phenotypes, we learned that it was much more complicated. So these are some data where we looked at lactate in patients coming for an emergency angio in Denmark, and we found that 97% of patients have either had cardiac arrest or have no shock, leaving 3% potentially eligible for the study. And then you exclude RV failure, aortic valve disease, and other things. So we ended up being able to randomize about 1.5% of a STEMI population. So going for 360 patients, you need 25,000 STEMIs. And I think that's one of the really important take-home messages of this, that this is really a selected group where we have tried to increase the likelihood of benefit as much as possible. I'll discuss it a little bit more at the end of the talk. So it went really slow for the first years. And the first 5 years we were running it in Denmark as the Danger Shock trial. We almost gave up, and then the company supported us with funding, so we were able to enroll patients in Germany first, and later on in the the UK, and the study became then Danger Shock, and we were able to finalize. Importantly, 2/3 of the patients have been enrolled during the past 4 years. So even though it took a very long time, the majority is the last years. The population we ended up with was predominantly male. They were about 67 years of age. It is a STEMI population, so this is not patients lying in the ICU deteriorating into shock. They had a median of 4 hours from onset of symptoms until we randomized the patients. The lactate was 4.5, ejection fraction was low, and importantly, the blood pressure was quite low and somewhat lower than what has been seen in some of the other studies. And I think this is maybe also a key to the benefit. Most have seen the survival curves, numbers needed to treat was 8, absolute 12.7%, risk reduction, a p-value of 0.04, so not a very strong, but still in 360, a pretty powerful effect to get a p-value. Of course, it was not significant at 30 days because we had designed it to be positive at 180 days. So 30-day mortality is not an endpoint for our study. And that's also something that should be remembered when discussing these data. We had a lot of complications. Some were foreseen, some were unexpected, like the renal replacement therapy was not expected that we would see 42% renal replacement therapy in the impeller-treated patients. So back in April, I concluded that this device could save some life. It was associated with unacceptable many complications, and this cannot be extrapolated to other populations. At that time, I thought now I had earned some time off and could relax a bit. I couldn't have been more wrong because the social media and everything went just totally berserk with all these discussion, and a lot of the things that was discussed there is also discussed in our in the correspondence in the New England Journal of Medicine. And I'll just touch a little bit about a few of these issues, and then we will have good time for discussion afterwards. But some that has been really discussed a lot is why was the controls only 3 days in the ICU, and why was the mortality in the control group so high? And I think a lot of this comes down to the phenotype. Some have elaborated, of course, that it was the way we treated the patients, and being Vikings, that maybe have affected it. But I think when you dive into the data, you see some really interesting things. And this Kaplan Meyer curve is from the independent patient data meta-analysis that was just published in the Lancet. Here we compare patients in danger shock without resuscitation, so no resuscitation at all in danger shock, with patients from ECLS shock and the other ECMO trials without resuscitation. So in the other ECMO trials, there were 111 patients without any resuscitations recorded. And in danger, we had 143 in the control group. And comparing these two groups, the outcome is identical. So there is at 6 months, no difference in these groups. So our control group don't have a higher mortality than what the same patients had in the ECMO trials. And the other thing here that is interesting is that the late mortality from day 30 to day 180 is actually even numerically lower in the danger controls than in the ECMO controls. The other thing is the question about the ICU stay. And if you break it down, we have more patients dying within 3 days in the control group. But we have also a lot more patients that are discharged from the ICU within 3 days. So after day 3, there was 111 patients in the control group or in the impeller group and 74 in the control group. And if we look at these patients that are early discharged, these are almost immortal. So they have a survival in the control group of 90% at 180 days. So these are patients that recover function fast and are discharged from the ICU within 3 days and are also discharged from the hospital alive. So these patients do really well. And I think this really, together with the higher number of patients dying early, drives the duration of the ICU stay. These patients that we cannot get out of the ICU, there the mortality is 63% in the controls, and almost half of this population were escalated to another support device. So these patients, we can't get out of the ICU there. They do really poorly. But there are a group of patients that are really interesting that recover fast, and we have to try to target those because they don't need a device either. So I think but for me, this explains the ICU stay. Then there's the kidney injury, and what we see that is somewhat comforting is that at 6 months, none of the patients that needed kidney replacement therapy during hospitalization was still on dialysis. So either the patient may have died or the kidney recovered. We saw that the need for kidney replacement therapy was within the first 24-48 hours. So this is not rising creatinine, it's patients that stop diuresing that is the main driver of this. But it's a very real signal, and even when adjusting for competing risk, we still have a significant higher proportion of kidney injury in the impeller-treated patients. And the paper on this is currently in review, and we see some interesting signals that it's definitely very closely associated to suction events on the impeller. So I think it's driven by hemolysis from the impeller. Finally, last Monday, Holger Thiele presented our independent patient meta-analysis at ESC. And what we tried here was to elaborate more on some of these things, what the reason was that some studies had a positive and some had a neutral outcome. If we just mix all the studies, it's like, for me, mixing apples and bananas. You don't get a signal. So routine use, just uncritical to all AMI shock, does no good. There are some subgroups that were interesting. So a poor TIMI flow or very low blood pressure could signify some effect here. But for me, the main take home of this study was the fact that now trying to target a danger-like population, we had almost 600 patients, and here we had an even more robust signal of benefit. So for me, it comes down to the phenotype of the patient. So if we should try to summarize all this, I think the first and foremost is that the shock team should evaluate, is this a patient that is candidate for MCS or not? Then we should evaluate, is this a comatose out of hospital cardiac arrest? If it's not, there are good data now to suggest that some of these patients will benefit from mechanical circulatory support. If it is cardiac arrest, we should wait, stabilize, optimize, and only if that fails and we still have very low cardiac output, we should consider ECMO or impeller in some of these patients, but the vast majority will not need it. So with that, I thank you for your attention, and I look forward to the discussion.
Yes, thank you, Professor Møller. Great data and really interesting topic, and we're looking forward to response of Professor Desch.
Just to remind everybody watching this is really a landmark study. When looking at history, there are, to the best of my knowledge, only 3 large randomized trials which were positive in AMI-related cardiogenic shock. That is the long time ago, 25 years ago, shock trial, which basically proved that revascularization, either by PCI or bypass surgery, is superior to medical treatment, just in general. And then it took 20 years for another positive trial, but in a selected subgroup of patients, and that is the culprit shock trial, which has shown that in these patients with infarct-related shock, culprit lesion only PCI is superior to a multi-vessel PCI in patients who have at least 2-vessel or 3-vessel disease. So this is just a reminder, this is really a breakthrough in treatment of this very difficult to treat disease. We've been comparing this trial to the ECLS shock trial a lot, but I just want to make another comparison, and that is to some previous observational studies. So there have been some observational data before the Danger trial came out with really bad results for impeller, comparing the impeller pump to IABP, which can be kind of considered a mechanical placebo device. You can see here a very large registry from the United States, and in the end, they ended up with a matched comparison of a little more than or close to 700 pairs. And what they found was very different from what the Danger results looked like. There was a higher rate of mortality in the impeller group compared to IABP. And of course, which has also been shown in all trials, a higher rate of complications. So when I was asked about a year ago if Danger would be positive, I actually said, no, I don't believe so because of these data. But as we learned, and as Jacob pointed out, this is another trial going in the same direction here. It's probably the selection of patients that matters most. It could also be, of course, some kind of statistical methodology like the matching process, but I don't believe that's going into the right direction. I think these kind of observational data are just too general to really select the patients who might benefit from this kind of therapy. So this is just to compare or to put these things into perspective, because a lot of people ask, why are the results so different from the previous observational studies? And this is my take on this. So this is the first point I wanted to discuss. Maybe Jacob would want to comment. Very unfortunately, that the RECOVER-4 trial, another randomized trial in the field, has been halted after the Danger results came out on the grounds of ethical concerns if that patients would be randomized to the control arm. So this is, of course, something to discuss, especially since the Danger results had a p-value of only 0.04, so they were borderline positive. 1, 2, 3 patients could have changed the results in the other direction. So from a trialist perspective, it is kind of sad that the RECOVER-4 trial was halted. Any comments, Jacob, on this?
Yeah, I agree that my scientific heart think it was wrong not to go forth with RECOVER-4. We were ourselves a RECOVER-4 site in Copenhagen, but we had also up front discussed, could we, after struggling 10 years randomizing these patients, go on for the next 10 years, randomizing the same patients when we had this positive result. And actually, our ethical committee challenged us and said that they thought it was wrong for us to continue in the trial. But I do agree we need more data. I don't think we will get those data after the Recover 4 stops. Ulysses will not give the answer because there's way too much cardiac arrest in that study. So for me, the meta-analysis was really, really important, that there seemed to be a more robust signal when we when we take some more patients from the other studies in. But as a scientist, of course, there should be more studies.
Yeah. Okay, so this is my second point here. Why are the results from Danger Shock and ECLS shock so different? Just as a quick reminder, I'm going to show you the results of the ECLS shock trial once again, which are pretty easy to comprehend because the survival curves are pretty basically overlying each other. So there was absolutely zero signal of benefit for ECLS in this patient cohort, whereas the complication rates were high. So and people have been asking, what's the reason for the differential results between the two trials? So just to remind you, there are some aspects of the ECLS shock trial, some of which Jacob has already mentioned. And the most important one is probably that over 75% of the patients were resuscitated before randomization. And by resuscitated, I mean oftentimes long resuscitation. It could last up to 45 minutes. And we know as clinicians that these patients are very likely to suffer from a brain injury. And this is really diluting the trial population. Also, it was a trial of routine ECMO, not a trial of bailout use or even eCPR in a resuscitation setting. So everybody who was eligible for inclusion actually got VA ECMO. There have also been other designs out there, like the EuroShock trial, which was halted early, but they had a different approach. They did the PCI first and then waited for the patient. How do they do after PCI? And only after about 30 minutes, they decided whether to randomize a patient or not. So we did it a little different in the ECLS shock trial, which facilitated inclusion, but can, of course, be criticized. Only patients with infarct-related cardiogenic shock, that should be clear. The ECMO was started in the cath lab in almost all patients. That is very soon after hospital admission. So it was not a watch and wait strategy approach where you could wait for the patient if he deteriorates after 1, 2, 3 hours and then decide. It was really an upfront VA ECMO treatment in all patients. And then one point which was kind of surprising to us, we had a very low unloading rate in the VA ECMO per group of only 6%. You know that ECMO is not really the ideal device when you look solely at the heart, because it increases afterload with all kinds of negative effects on the heart, which might be important, especially in a state where the heart is already affected. So to come up to the original question, there have been like all kinds of theories, and the most important one is probably patient selection. Jacob already pointed that out. In the Danger Shock trial, we had only STEMIs, which I believe is, there could also be probably NSTEMIs who are eligible, but more important is probably the very low resuscitation rate. And those patients who were resuscitated were only resuscitated very briefly, and all had a Glasgow Coma scale above 8 when they arrived at the hospital. So these are not the real resuscitations with ongoing comatose state. And quite contrary, in the ECLS shock trial, as I pointed out, we had a very high resuscitation rate with all kinds of comatose patients. Then down below here, you have the device. We already mentioned this. Impella is in principle a more favorable device in the failing heart because it's an unloading concept as opposed to VA ECMO. So this could also be a reason why the Impella fared much better than VA ECMO in these patients. And then you have one theory that came up after Danger came out, which I don't really believe in so much, but I just want to briefly mention it, and that is kind of a treatment bias in an open label design study. Jacob mentioned the quite high renal replacement therapy rate in the Impella arm versus the control arm, which Jacob, you explained by the suction events in the Impella group, which is plausible. In the end, we will probably not definitively know the answer to this question, why this happened. The ICU time was a little longer in the Impella arm in the Danger trial, which is not so surprising to me either, because if you have a device in there, it probably takes some time to take care of all of this. I think you had a median time of close to 60 hours on the device. So, and then you have to remove it, and this probably prolongs ICU time in itself.
Thank you, Stefan, for that great integration of that data. And to wrap that up, I learned that carefully select and be reluctant, watch and wait after out-of-hospital cardiac arrest. And maybe, again, the question to you, Jacob, for our viewers who are colleagues but may not be as used to the business, could you just in 2 or 3 sentences wrap up, what is the difference between patient without out-of-hospital cardiac arrest and with arrest? Because for most people that groups may be put into one and shouldn't one should not worry about, but it's not the case.
Now, for me, it's 2 different phenotypes that present very similar. So the cardiac arrest patient has the down period during resuscitation, and often the heart will recover function quite rapidly. So when we see patients coming in, they often, the cardiac output at that time is not that low. What I call LV predominant, they have the really low blood or cardiac output. And all these devices really can is to create cardiac output and create flow. So for me, the basic take home is that you have to make sure the cardiac output is low before you put in this device. Otherwise, it will just create a lot of trouble.
Another question I want to address is, Stefan, you mentioned the major difference between the devices. ECMO, LV afterload increases afterload, and Impella unloads the ventricle. And maybe the question to both of you, do you, at your centers, do you unload? Do you recommend both combining both concepts, as some centers, as my center sometimes do? What's your opinion on the combination of the 2 systems?
Yeah, I guess you already said the word sometime or sometimes. So I would probably agree. There is some interesting, although not randomized, data out there that the so-called ECMella approach, that is ECMO plus Impella, actually is associated with a mortality benefit, which is a little hard to believe, but anyway, these are the data out there so far. So there there are arguments in favor of additional unloading by Impella, but remember that now you have a lot of large bore cannulas in the body, so that really increases complication rates. So there are other methods of unloading apart from Impella, some of which are a little less invasive, but also a little less effective. So it remains to be proven. There is a very small first randomized study out there, which has been published at the end of last year, but which is of little value because there was a very high crossover rate from the non-unloading arm to the loading arm. So it didn't show any significant effect. So it was a neutral trial, but it's really nothing to count on. So the question is still open. What's your take on this, Jacob?
I can only echo you that this is something for highly selected cases to do the unloading. In our study, the rate of complications when you start combining the devices is just it's really scaring. Like 65% bark, 3 to 5 bleed. If you were on ECMELA in Danger Shock, it's not something to take lightly. So my take is that we should do the randomized trial. We should support Benedict and Dirk Westermann on their study, and we're working on joining them in Denmark. So I think we need the randomized trial, but we would occasionally do it, but not routinely.
That's the trial you mentioned. It's the early unload trial, but they are in a way they are kind of similar to Danger because they have like very slow enrollment, which is hopefully is going to pick up in the future, just as in Danger. But it would be an important trial. Yeah. Then of course you have the overriding question in trial design. Now you have a treatment via ECMO in infarct-related shock, which has proven, all criticism aside, to be non-effective in this population. And now you add on the second subtherapy, that is LV unloading by Impella. So there are some ethical issues to be discussed also in this regard.
I agree. It's tough. And the way we will run it is it's only when the shock team has decided to put a patient on ECMO, then we can randomize into the ECMO unload study if we start up. But it's also interesting what will happen to the guidelines after these studies have come out. So the heart failure guidelines is probably what is coming out soonest.
If you want, I can show you some additional slides. This is like a minor point, but we are really deep diving into the data now, and that is the mortality effect by country in the Danger trial. So if you look closely at the control groups here, you can see a 64% mortality in Denmark, as opposed to Germany and the United Kingdom with 49%. So, and you can see really the positive results are really driven by this huge difference in Denmark between the treatment arm and the control arm. So the reason is speculative. I don't know the reason either. It's just something that's striking me watching these data. Do you have any, I know you don't have solid data to explain this, but do you have a hypothesis why this could be?
Yeah, my hypothesis is that these patients were sicker actually in Denmark. So they had significantly lower blood pressure, they had significantly lower ejection fraction, significantly higher lactate at the randomization, but they still had the same. It was not because they had longer duration of from onset of symptom until randomization. So I think in Denmark we randomized a sicker phenotype, really. So they are not completely the same. And if you adjust for these things, the difference between the countries are less. So I think it's, again, it comes down to the phenotype. Some may be driven by the early years before Germany, when the control group was less likely to be escalated, and that's very speculative again. But my take on this is that it's because they were sicker.
Yeah. And on to another point. Jacob, you mentioned the meta-analysis of all the randomized patients, whether it be to the ECLS trials or the Danger Shock trial. And you also mentioned that the signal that danger-like patients overall, whether they receive an Impella or ECLS, becomes more robust in the danger-like phenotype. And when you look only at the danger-like patients in only the ECLS trials, that is not only ECLS shock. There are a few other very small randomized trials, and if you just pool these patients without the danger population, this signal is no longer there. So we really have to question whether the danger-like patients do indeed benefit from VA ECMO treatment. The question is still out, but I would be a little cautious in just extrapolating the positive results of Danger to the same population in the ECLS shock treatment.
I completely agree, and in the meta-analysis and this analysis, we are not really able to match to the danger phenotype because what we did here was that we set less than 10 minutes resuscitation was a danger-like patient. So it's a very rough way of doing that. So unless you really had the GCS or scale or something else, it's really tough. And I do agree, we cannot take this into to interpret this and say, now we know that ECMO works in this phenotype. I definitely don't think we have shown that.
So coming to phenotypes, and this might be interesting for the viewers who work in clinical practice, I want to discuss a little who are candidates for Impella. So like further pinpointing the ideal phenotype, I would say. Of course, you could say you just follow your excellent inclusion criteria from Danger, and that's it. But I want to deep dive a little further into the data and maybe have some theories which patient could benefit most. And my first glance was looking at some of the subgroups. So the first subgroup that really was I looked at was the sex category. So you can see here the majority of patients enrolled, about 80% were male. And in these patients, you can see a clear positive signal here, whereas in the female patients, it seems to be more of a neutral effect. Now, this could be, of course, because of lack of statistical power, but there is also some argument in case for example, access complications. So female patients usually have not the most favorable anatomy in terms of size of the access vessels. This could be just one explanation apart from statistical issues. The other one, which is probably very important, is age. You can see here that the younger patients, I think it is divided by the median of age here. So under 67 clearly benefits from the Impella treatment, whereas the older patients, it goes more into the neutral direction. And when we talk about older, I think the interquartile range, correct me if I'm wrong, Jacob, went up to like 76, 77. So if you have a patient in the very outer limit of age, I would be very hesitant to place such a device in. And then we have the arterial pressure. So you can clearly see here that the lower the pressure is, the better the effect of the impeller pump seems to be. And integrating all these data, it could give you some hint on the ideal candidate for impeller treatment. So that is a STEMI, non-comatose patient, maybe a little younger, preferably male with very low blood pressure. What do you think, Jacob? Is that a good idea?
I think you're spot on. We have a paper in review right now on AIDS, where we see that patients older than 77, which is, as you said, the highest quartile, they do not benefit from the device, and over 80, we should really think twice before placing the device. The sex history is a little bit more complex because firstly, I just thought smaller heart, smaller vessels, it runs worse there. But looking into the data, it's really driven that females are 10 years older than males in the study. And females, they come to hospital twice, they have time from onset until randomization almost twice as long as it is in the male. So they have a much longer time before they're randomized, before they come into hospital. And even in the hospital, the treatment delay is longer in women. And I think that's something we have to address as well. And for the blood pressure, I completely agree.
Yeah. So when we talk about the ideal phenotype, we also have to talk about complications. And I want to share with you a sub-analysis of the ECLS shock trial, which we have submitted, which is under review. And this is the question here. Are ECMO complications causal for mortality? And we tried to somehow tackle this problem with the different statistical methodologies, which is very difficult because all have their weaknesses. But still, we came up with the following conclusion: that there is no significant mediation effect of ECMO complications on short-term mortality. So although these complications are serious, they do not seem to be causal for mortality. All weaknesses of such analyses aside. And I assume that the results would be very similar in the danger population. And now I want to discuss in my last slide here, what could be the possible future guideline wording. And I've already created a draft. Please don't cite me or quote me. And this is my take on this, that we can discuss it. So I try to emulate the typical guideline slang. In non-comatose patients with STEMI and cardiogenic shock, the temporary use of a microaxial flow pump is recommended under consideration of an increased rate of adverse events, and I would consider this a class 1 indication based upon one positive randomized trial, although not with the level of evidence A, but B. And with regards to VA ECMO, I would suggest routine use of VA ECMO in patients with acute coronary syndrome and cardiogenic shock who undergo revascularization is not recommended. Yeah. So please feel free to discuss it. This is just a draft, and I will not be on the guideline committee, so please don't quote me on it.
Great, Stefan. Thank you. There might be nothing to add, but for a user, 3 o'clock during the night, and a question to both of you: when to expect increased rate of adverse events? When to think? What patient, what clinical scenario, what facts must let me think about bleeding and adverse event?
You certainly need to be proficient in the whole procedure. 3 o'clock at night is not the time to pick things up and learn it. you have to be proficient in large bore arterial access. Ideally, you are a, for example, TAVI implanter. This is really important. You should probably do the puncture with ultrasound guidance. In the very elderly patients, I would be a little cautious. But still, I would consider this, given the right patient, now the standard of care. So you should probably, if you don't know how to do it by now, you should probably pick it up.
You agree on that, Jacob?
Absolutely. I'm a cardiac intensivist, and all of these complications, they happen in the ICU. I think in the cath lab, they have become much better at addressing the problems there. And now we have to pick it up in the ICU and train people to see the signs when they begin to emerge that there's a problem. And a suction alarm on an impeller should never be taken lightly. I really think we have learned that. So we have a lot of work in the ICU.
I have one single question to add as nephrologist, surely. Is there any funding for you to have a longer follow-up of your patients to see whether or not those people who had acute kidney injury will have worse outcome over 1 or 2 years? I learned that nobody has been on dialysis after 6 months, but will we see longer data?
That's a wonderful question, and I'm writing the protocol for that. We have to make a new protocol to do this, and we have to go back to all the RRBs and new contracting in Germany. In Denmark, it's easy because we have registries, and it was in the protocol to follow the patients in the registries. We don't have that luxury in Germany. So it will probably take one and a half year before we have these data collected, but we will collect kidney function and look what happens on the very long term also for the kidneys. But it will take some time. But I'm writing the protocol.
So maybe as a last point question to you, Jacob, Stefan proposed some guideline wording. Do you want something to add? Is that good as it is, the proposal, or any comments from you?
I think if we make a class 1, I would have guessed a 2A, but after the meta-analysis, I think it might be a 1B in this very specific population. And I think the fact that the routine use of ECMO, I completely agree, it should not be done. But there are selected patients, but not routine.
Great. So as time went by, we both have to thank you, both of you, for coming. We learned a lot. We learned a lot of vulnerable population of patients, which is not what cannot seen as one. You have to differentiate. You have to watch and wait. You have to be profound with the procedure, and those devices are dangerous and should not be used in every patient. We learned a lot. Thank you both for coming and sharing the data and discussing with that, and even adding some new data. Hope we can read something new soon from you both. And with that, I say bye-bye.
Bye-bye. Thanks a lot.
Thank
Bye-bye.
you. Thank you.